This is an interview with Dr. Rafe Henderson about his role in the West African Smallpox Eradication Project of the Centers for Disease Control. Today is July 7th, 2006, and this interview is being done as a part of the 40th anniversary reunion of the launching of the Smallpox Eradication Project. The interviewer is Victoria Harden. Dr. Henderson, I want to begin by setting the stage for who you were in the Smallpox Project, and I like to start at the beginning. So I will tell you that if I am correct, I know that you were born in New York City on March 5th, 1937, and I would ask you to give me a brief account of your childhood and education, who your parents were, whether any of these early experiences nudged you towards medicine or public health.
Yeah, my father was born in Burma, which is the explanation for my nickname, Rafe. The British soldiers in Burma, who were then in charge, used Rafe as a nickname for Ralph, and my father's name was Ralph, and when he named me Ralph, then they called me Rafe as a nickname, so that explains that. But it also explains that my orientation for international health. My grandparents were medical missionaries. Their grandparents were also medical missionaries in Jamaica. My uncle was a medical missionary in China. My father was the black sheep of the family. He went into the Reader's Digest for publishing. But my brother became a physician. I became a physician. And when I was doing my internship at the Boston City Hospital, I was contacted by somebody from CDC who told me about the Epidemic Intelligence Service. And that, combined with a lot of my other interests in the international sphere and missionary work, although my father was not religious and I'm not particularly either, seemed to be a very good next step for my career in public health.
Let's drop back a little bit and ask you to talk about your years at Harvard. You were at Harvard for both your undergraduate education and medical school. Was there anybody on the faculty who was particularly important to your career?
Yes. Obviously in college one always has heroes. Mine was a psychologist named Jerry Brunner, who was dealing with cognitive psychology, and I found that very interesting. I won't tell you the funny things we did, but in any case, it was an interesting time at Harvard. I was there only 3 years because I had spent the year prior to going to Harvard as an exchange student for the English-speaking Union. So I was in the UK for a year in what was a public school before coming to Harvard, so I was only at Harvard for 3 years. Then I went on to medical school, and in medical school, many of us were very, very influenced by Professor Thomas Weller, who had worked with Enders, Robbins in developing the polio vaccine and later on the measles vaccine. And he was very eloquent about tropical public health and the challenges and the needs that were going on. And as I say, a whole bunch of us came out from under his tutelage very interested and, well, let's say interested, because we were too young to be career committed to that at that point, but I think that was a strong influence.
You joined the CDC immediately after your internship and residency in the Boston City Hospital. Were you one of the folks joining initially to avoid your, not to avoid, pardon me, but to discharge your military obligation?
Well, I think it's a very good term, because I think in many of us that was 1965, 64, 65. It was just starting. And the choice of how does one want to spend one's military career was certainly a very vivid one for us. I would like to think that my own reflexes, both seeing the difficulties of practicing in a city hospital where you're getting end-stage disease and not being able to do very much about it, and my interest in international health combined to make the CDC a choice whether or not there had been a military draft. But it was clear that that served the best of all purposes as far as I was concerned. I was not interested in serving in other areas of the military, was very interested in serving in what I knew at that point about what CDC was doing.
In public health service.
Right.
So in 1965 and 66, you were an EIS officer. Would you talk a little bit about these early EIS, your training and the assignments?
Well, it was incredible. We came out of, they used to call the interns in those days the Iron Men because we didn't get salaries. We ate at the hospital. We often slept at the hospital. We had one set of clothes. To come to Atlanta, to be presented with, I think we got a slide rule, we got a salary, we were treated like important individuals. It was incredible, absolutely incredible. And we had a very exciting course during 6 weeks or so, what was called the EIS course, training us in sort of shoe leather epidemiology. And again, because of my interest in international health, I opted or tried to apply to the smallpox program, which was, or the smallpox unit at that point, was lucky enough to be selected, and then lo and behold sent off in very shortly after the training to West Africa as a technical advisor to the French public health organization in the west part of West Africa called the OCCGE, and that's a very long name, but part of it translates into the Grand Zone de Mie, the great endemic diseases. And the reason for going over there was that USAID, well, let me go back 2 steps, and you may already have this from other folks, but in about 1963, roughly, the NIH conducted a major field trial of measles vaccine in West Africa, beginning actually in Upper Volta, as it was called. And it was an astounding success. They covered most of Upper Volta in about a few months with mobile teams and did it very well, had high vaccination coverage, and measles pretty well disappeared. Now that was a self-serving exercise in that we, the United States, wanted to test the measles vaccine on large scale. Here was an area where this could be done, where it was desperately needed, where kids were dying of this disease, and you would have had to have a very, very bad disease, bad vaccine indeed, not to be ethically justified in doing a combined trial and of the immunization, of the vaccine itself, and seeing what impact you would have on public health. Well, the impact was absolutely astounding. And the briefing I got was that one of the reasons that USAID was willing to go along with DA Henderson and others at CDC in joining a smallpox eradication program, which they weren't interested in, with the measles program, which they were interested in, was that they knew that they couldn't do much with the measles program unless they had some good technical support. They'd had some disastrous experiences without technical support before they launched the full program in '66. But it was perceived that because the U.S. had the measles vaccine and no other nation did, that a measles immunization program allowed the U.S. an entryway into West Africa where the French culture was dominant, that did not compete with the French either on educational grounds or on economic grounds, but here it was a neutral health ground, very popular. All the countries desperately wanted it because measles was such a bad disease. And so I went over as a sort of one of the people to help out in the stages before the full program got going, and was advising this OCCGE, the French Public Health Organization, in running these mass immunization campaigns with measles vaccines. Now, the French were very good at doing mass campaigns. There's no problem with that. The problem was they were not very good at dealing with this funny electrical jet injector, which is what we were using to administer the vaccine. And they were not very good at dealing with the very many difficulties in supply and logistics posed by our USAID and U.S. government contributions to the programs. And so when I arrived, or at least one of my interviews with the Ministry of Health in Upper Volta, with the chef de grands ennemis, the French advisor who was running the grands ennemis, he was furious because our 5 Dodge trucks that were given to help or actually administer the vaccines were consuming his entire budget of gasoline for his entire grands ennemis. And the USAID deal was, we give you the trucks, but you run them. You pay for the gasoline. And of course, that just wiped out the budget for the Ministry of Health for gas, all of these enormous trucks that were consuming all the gasoline. And so he was not a happy person.
Was there any solution to this problem?
They did the best they could. They were unhappy, but they did not a bad job with the things. One of my problems was firing off cables about getting spare parts for the jet injectors. They kept running out of some tiny points that I didn't know what they were, but I think they would be in a regular engine, something called the points that are dealing with the electrical. Forget it, but that's all I knew. But I knew that they were burning out and they couldn't get spare parts, and so one of my jobs as a technical advisor, very technical, was to send cables back saying, send more of these things because they can't run the injectors. And nor did we send enough diluent, so we were often using Evian, one of the French bottled waters, as diluent for the measles vaccine. So I saw in that, I was over for about 6 months, traveled widely in those countries, was treated extremely well by the French advisors, even though they knew I didn't speak very good French. They knew a lot more than I did about anything they cared to ask me about. But they were very gracious, very good about teaching me and helping me learn about things. And as I say, I think I saw in those 6 months enough problems to last me the rest of my life about understanding what can go wrong with an immunization program and with other kinds of public health programs that you're running. It was extremely valuable.
Well, I think one of the points that has been made over and over here is that medical knowledge about smallpox was really only the first step to eradicating smallpox, that the logistical problems and the personnel problems and the diplomatic problems, all of these things were key to eradicating the disease. So you were seeing this in advance of the project.
Yeah, but I think, yes, I think that's very true. I think the CDC tradition, though, is an important one to emphasize. We, medical people, went over with public health advisors who joined us as non-medical people who were there exactly for the management issues. And I think CDC had a long tradition of this in the venereal disease control program, as it was called in the old days, and then branched out in tuberculosis and many other programs where there were always public health advisors who were trying to get the logistics, the management right. And so I think the CDC optic was, we've got to have some medical expertise to be credible, but we really need the management to be sure that we can be effective. And I think that had been the really key to success of much of what we did. And maybe just go back a little bit about the medical knowledge of smallpox. We didn't have such great medical knowledge of smallpox, if I can say that. The program was designed to immunize everybody in West Africa against smallpox, sort of 100% vaccination coverage. And we didn't find out until a couple of years into the program we didn't need to do that. And that was one of the really startling breakthroughs in the program, the ring vaccination of simply immunizing around active smallpox cases, breaking the cycle of transmission, and not going all out to maintain high levels of immunity in all sectors of the population. We learned that relatively rapidly, I must say, within a year or so of the program, but it was a major conceptual breakthrough for us.
Would you walk me through the setting up of the regional office in Lagos? You were the deputy director and the epidemiologist, and no one else, Dr. Lithcott, is no longer alive.
Yep.
And so tell me about how it was formed and how it functioned.
Well, it's a funny thing. I have very little idea about that. I know that there was to be a regional office. George was the director. When I was in West Africa and the full program came into being, I was then recruited from my role as an EIS officer to then join as the deputy chief of the regional office. George had worked in Ghana and a senior person, very well respected, and it was perceived that if we were going to have a regional office, that we should have a regional office. And in the early days, as I understand it, the idea was, yeah, this would be one regional office, and as the program expanded worldwide, as we got rid of smallpox in West Africa and then moved to other regions, there would be other regional offices in other regions that were similarly constituted. In the event, we never did that. That was the regional office. I was there, yes, as epidemiologist, but I was one of the few people who spoke French and didn't speak it very well, but that was what it was. So my responsibilities were mainly for looking after the Francophone countries. And so my role as deputy was sort of doing all hands work, and we had an equipment specialist with us, we had a very good health educator with us, we had a statistician with us, we had a secretary who had been knowledgeable in working in West Africa before. I think that was and Jim Hicks, who was our senior administrative officer, who was very effective. And George, as the director, dealt with all the terrible political problems that were really insolvable, and he managed to solve most of them. And Jim Hicks really dealt with equally difficult administrative problems. Who had furniture in their houses just in Lagos? Could we get cars in the early days? What was going on with the financing of things? He had all sorts of fights he had to do with the embassy and the USAID mission, who didn't really have the resources to give the support they were supposed to our group in the regional office.
Now you, as I understand, wrote most of they called them E1s, the programs for each of the countries, in the Francophone countries. Is this?
I don't remember that. It's at my age, I'm finding that happens more and more often. I do know that I spent some time going around with George Lithcott and Henry Gelfand, who was from the headquarters office here, trying to finalize and write what we call PROAGs,
yes,
project agreements. That's right. And I recently got a letter from, or a communication from a colleague that was working with us in West Africa, where he sent me some of the letters he had sent me. And he quoted me as saying, he was asking, could they give some of the cars that had been assigned to them as advisors to their national counterparts? And he said in the letter to me, and I understand, Rafe, that you had already anticipated this in putting the request in for these cars, knowing that they would be needed by the ministry, and that you couldn't justify it just for the ministry, but you would justify it by giving it to the advisors that were there, anticipating that they would then be shifted back. I have no recollection of that at all.
There was, at this point, however, some tension between CDC personnel and USAID as to whom the CDC reported, whether they reported to AID or reported to back. And I think it fell on you to clear the air about this, if my reading is correct.
Boy, I don't remember that either very much. I do remember going to a couple of countries. My wife and I were talking about that, and I remember being in Chad, and I was trying to figure out, why was I in Chad? And then it occurred to me there was something going on with USAID and our staff there that I apparently was trying to mediate. And again, I don't remember the details of that. I do remember that there was a general problem when we from CDC came into our countries, and we felt we were masters of the universe and owed nobody any comeuppance at all. Neither USAID or the embassy. We were there, we had a mission, we were going to get our stuff done. And so that was a general tension that I do recall. I don't remember my role exactly in what I did about it.
You were telling me earlier about, you started to tell me about developing the cluster sampling system and the instruments here to do the sampling. Would you explain, for the record, what cluster sampling is and how you developed it?
I can, but I would also like to go back at some stage to lead up as to why I ever got into that.
Okay, well, let's go back.
Well,
tell me how you got into cluster sampling.
All right. I had come back from being sent off to India in the spring of 1967 when there was a smallpox outbreak. And we were expected to eradicate smallpox in India in a very short period of time. Did not succeed in doing that. Came back to CDC and found that my wife was with me, and in the interim the Biafran War had broken out. She was then not allowed to go back to Lagos as a dependent. I would not go back to Lagos without her, and we arranged a compromise. As my range of responsibilities was the Francophone countries anyhow, I did a whole series, 6 months or so, of continuous consultancies, firefighting, all sorts of stuff in West Africa for 6 months or so. And then the Biafran War settled down. We were able to go back to Lagos. I got back to my regular job as deputy chief of the regional office and got myself promptly into trouble with headquarters because I kept feeling that the policies that we were being asked to follow by headquarters were not the best ones for us in the field, and that there was not a very good understanding of what was needed here in the field.
And when you say headquarters, you mean here at Atlanta?
In Atlanta. So I became a very shrill voice, I'm afraid, demanding and being troublesome. And I don't remember whether I was called back or whether I had to come back on for another occasion. But when I did get back here at CDC, I was pretty well told, enough of this nonsense. We need some assessments done. Go do them. Again, my memory is foggy, and it may be that there was a lot of help, but I don't remember. What I remember was going off and saying, oh yeah, okay, we need to do assessments, and it turned out to be 3 major assessments, one in northern Nigeria, one in western Nigeria, one in Niger. And I brought some reports that I'd been looking at recently and trying to scratch my head. And yeah, the cluster sample survey was part of that assessment or evaluation. There were also aspects where we reviewed records, we interviewed people, we looked at health centers, we inspected vaccination teams and the rest of it. So it was a very extensive project. And what is astounding to me in these days is that for the cluster sample survey, and let's talk now quickly about that, if you do a random sample, if it was the Gallup polls will do in the United States, and you can get away with sampling a relatively tiny fraction of the population, but you have to do it in a very meticulous, random manner, so that the individual that you select is not selected with any bias that you can imagine. This is very intensive, very expensive to do, very difficult to do. A compromise that was developed by CDC staff, Surfling and Sherman here in the United States, was a cluster technique. And that meant that rather than taking a single individual and asking their question, you could take a group of individuals. But if you did that, you had to compensate for the fact that they were a group and no longer independent, so that one of the group had more similarities to the second member of the group than if you'd taken a totally different person from it, because the cluster was a geographic cluster. So you would get households that were all together, or members of a household that were all together. So that was the cluster part of the cluster. Rather than sampling as individual people, you clustered in groups. So we had the Surfling-Sherman technique, which we had learned. I learned as an EIS officer. We did a sample in Atlanta. Bill Fagey did a modification of that in the Gambia early on. I knew about that. And when I was asked then to run these surveys, run these evaluations, and do a cluster survey as part of that, then I further adapted that survey. And boy, did we make inroads on that. I look back on now, it was incredible. How am I going to do a survey in a huge area of the country? What kind of a sample do I select? How do I get the records done? How do I collate them? How do I taught myself to type. I didn't know how to type. I realized that when I have to write these long reports, I was going to have to type. I realized I was going to need some way of recording the data. So I had worked in my own files with McBee cards, strange animals. I'm just going to hold up one, but it's a strange card with a lot of holes around the side of it. And you punch a notch in that hole. Each hole can correspond to something you've written on the card. So, for example, I had, is this person that you're sampling a male or a female? Male 1, female 2. All right, they check 1. I punch, or they punch, 1, which is numbered on the end of the card. At the end of the day, I get 100 cards together and a knitting needle, and I run the knitting needle through the 100 cards at the number 1. And lo and behold, all the cards that have this punch fall out if I shake them vigorously enough. That was the other part about analyzing the things. But they were fascinating to use, difficult to use, but a godsend, because I could then train teams who would go out with these cards, and then while they were in the field, simply mark a number for each of the data systems I had. And then at the end of the day, they would, at their leisure, take a paper punch and punch out these holes that corresponded to what they had found during the survey. And then I collected all the cards from all the teams at the end of the day, and then went home and spent a long time shaking knitting needles and having the cards fall out, and I'm sure with a lot of errors involved with the things. But it was absolutely an incredible exercise, and I can't believe, even to this day, that I was able to do that with very short notice, to go in to design the cards, to decide on that, to decide on the sample surveys.
Actually, can we just go ahead and get a shot of the card right here while we're at the beginning of the tape? Just hold it up like you did, Rafe. I think you were a little lower than that.
We got two cards front and back, so you want to get...
Well, no, I think
oh, okay.
Because the detail is not important.
He didn't speak but like maybe 5 seconds on it, so you might not have time.
Yeah, no, I don't think it's worth going into the detail on that. It's just really what a card looks like.
But you can see the numbers around the outside in the holes where you would punch with the numbers. That's the important thing, and how you code it down there.
Yeah, you can see it.
Okay.
Is the other one different, or is there?
I can shoot it too. Doesn't matter.
Well, it's for a market, but it's the same issue. It's got data on it and holes in it.
I think you ought to shoot it though, because it's
hold it up.
one is individual and one is group.
Yeah, but now I don't know which is which.
I think you had the individual.
Okay.
So you want the market.
This is the village. This is the village and market assessment, I think.
Oh, I'm sorry. Need to do it that way.
Did we get that one already?
Yeah.
All right. So this is the other one.
All right.
Okay.
Good. You ready?
No, just a second. Okay, go ahead.
But I want to talk a little bit about the actual sample survey design, because that was fascinating. What are you going to do with a population that is so varied as you have in West Africa? Yes, you've got some people in cities, but you've got people in villages. You've got people that don't particularly go to village. They're nomads and all over the place. And I'm, again, just impressed with ourselves, myself, in that time. We designed the sample surveys, so we tried to get probably not a valid sample, but at least an idea of these various groups. So we would go into a village. For example, we could have a sample survey that said, let's take a valid statistical survey of all the villages in a catchment area or a state or a country that are under 5,000 population, because perhaps we thought under 5,000 would be a high-risk group for smallpox. We'd get all the villages. Okay, so you select, say, 30 villages out of those. And then we said in each village, okay, you do the village, you get your sample from that village, but then leaving the village for the next 10 kilometers, you stop every person you see and you interview them, no matter who they are or what they're doing. And then we said, in addition to that, you go to some of the local markets and you do a market survey and find out who's there. And within the markets, sometimes you can select individual groups. We know they're nomadic tribes, and we can recognize them because they're wearing distinctive things. So we could say, and you survey 10 of the nomads from this area and 10 from that area. In western Nigeria, we had an area of the state that was very heavily influenced by fetishers, by the traditional people. And we knew that they had a cult that did not appreciate being vaccinated against smallpox. It was the Shipona cult. They were against vaccination. And we knew that vaccination coverage was lower in that area than in other areas. So we did a separate sample of the fetish area and the non-fetish area. We did all sorts of tricks to try to probe where we were weak. And it wasn't so much that the sample was going to give us a wonderful average of what was going on in the country. But my idea was, let's point the finger at where we think we're doing least well. Let's find out what's going on there. That's where we need to make the changes. And it was just a fascinating experience. That was part of the assessments that we ran into. Because we did other things as well. We looked at records, we interviewed people, we inspected vaccination teams. We found faults everywhere. There were problems everywhere. And that was one of the great lessons that I learned in my life. Despite all the problems that you find every day and you think nothing's going well, that isn't always the case. You can have some success despite it. The other thing that was impressive looking back now on this is that there was no stopping us. I mean, getting a sample survey, doing these assessments, that's no problem. We'll just do it. And I think it was the attitude of the entire program. We had a goal, we were going to do it, nothing was going to stop us. I'll tell you one other anecdote with that sort of situation. We got stuck in western Nigeria doing one of these assessments. We got often stuck in western Nigeria. It was during the rainy season, and we spent more time pulling ourselves out of mud holes than anything else. But we were in a rubber plantation for reasons I don't understand, but we were doing a survey there. And it turned out that the vehicle was running down on hydraulic fluid. The brake pedal kept getting weaker and weaker. And we knew when we left in the morning that we needed some extra fluid. We had some. But by the middle of the day, it was getting low, and we were running out of, and we finally looked under the hood and found that the brake line was rubbing against the engine and had cut a little hole in the things. And we said, right, okay, I know how to do that from an intern at Boston City Hospital. Give me some tape, and I'll tape it up. I taped it up, and each time I did it, because the hydraulic, the brake line has a lot of pressure at it, each time I did that, it just blew the tape away. It didn't work at all. We were down to our very last little bit of hydraulic fluid, and I said, right, what am I going to do? And we got some cotton that we had for first aid. I took some rubber out of the rubber tree thing that was, or not rubber, but the sap that was there, chewed the sap into the cotton to make a solid compress, then did a suture around the hydraulic line with the thing. The thing held till we got back at the end of the day. But it was a thing about, this isn't going to stop us. We can fix this. Nothing is going to stop us. And that happened over and over and over again to everybody in the program. It was incredible. And I think it was one of the things that made the program just such a success. People would not be stopped.
Now, do a little analysis here. Was it just because these particular people were so special and what have you? Was it an American thing? Was it inspiration from above? What do you think made this group? Obviously, it's a very special group. Do you have any opinions on this?
I hesitate to say it, but I'll say it's not a very special group, and I think that's the magic of it. Special in that the challenge was there. Yes, good leadership, good support, a strong image of what needed to be done. But by God, when you do that, and you give people responsibility and things that they've never met before, most times, most people will rise to that challenge. And I say that because I then had experiences later in life in the World Health Organization with other programs where we had the same sort of thing, where we had specific goals to get over, people from many cultures, many different things, still rising to that challenge in an extraordinary way. And don't forget, as I'm sure that nobody will, we were a tiny fraction of who did the work. People who did the work were the people who were there, the vaccination teams, the staff, the endemic folks, the villagers who helped us. We were there, our vaccinations were a tiny part of that. So let's be clear that we were helpers in a project that was done largely by national staff.
Were there any particular problems in dealing with the national staff that you recall, or were there good relations from start to finish?
I'd have to say mixed. I think the relationship got better as we all got more familiar with the environment and the cultures with which we were dealing. When we arrived, we, the CDC people, fresh out of the U.S., we were impatient. We didn't understand why nothing couldn't be done yesterday. What was the problem? And of course, the folks we were dealing with, whether it were the national ministries of health or often the French or English advisors who were there, the other expatriates, they thought we were nuts when we first arrived. They couldn't understand why we were having these expectations. Many of the French thought that the word eradication should be eradicated. They had very little briefing for a little time for this eradication concept. And so, yes, there were a lot of tensions with that, but I would have to say that, again, the experience of the public health advisors who dealt with those kinds of issues also in the United States with state and local health departments and recalcitrant public officials at all levels and learned to adjust and to find ways of getting things done so that everybody got along with it. That's where they really shone in those situations. So we in the medical officer field were not so often good at that, and I think we were very well served by having the public health advisors with us.
In December 1969, there was an observance of the 100 millionth vaccination in Niger. Were you involved in that at all, and did you have any special memories of that event?
That was in Ghana, and I have some memories of it. I wasn't involved with the organization, thank goodness, because it was a massive affair. But I do remember going and giving an interview to the Ghanaian TV station about things. And then when the interview, sorry, not TV station, it was the newspaper. We don't think we had a TV station, or it was very rudimentary in those days. And the newspaper interview talked about our work in, I think, eradicating rabies or malaria or something totally not having anything to do with what I had said or what the program was about. And I was also, one of the reasons I was doing that interview was that I think the Minister of Health or the other, or George, the director of the program, were off doing the 100 millionth, and they needed somebody to sit in, sort of satisfy the local news media that there was somebody there that would speak about the program. So my role was a very minor one, was sort of observing, but it was a grand affair.
If you were going to do the program all over again, would you change anything about the way it was run?
Given that it worked, I think not.
How did the Smallpox Eradication Program change your life and career, or did it?
Oh, very much. Yeah, no, the idea of, when I came to CDC, my idea was to work in public health and for a while go back to internal medicine, maybe get a joint accreditation in public health and internal medicine, as many of my colleagues were doing. But when I got to West Africa and had a little bit of experience there, two things. One, I was addicted to public health. Two, I had to go back and get some management training. So I applied to the director of the center, Dave Sencer, and asked him for a career development extension to go back and get a degree in public health at the Harvard Medical School. And I said, I know Harvard, and I will look during that first year at the School of Public Health, and I will find some management training that will be, I'll take the second year. I don't know what I was sitting in Lagos, so I couldn't tell him exactly what that second year was about, but I said it would be management. And in fact, I tried to get into the Harvard Business School, and they had a very rigid program that I thought was very unhelpful. The Kennedy School was just starting a program of Master of Public Policy. They wouldn't let me into it because they said I was too old. I think it was 28 or 29. And I insisted that I was just the right person, talked my way into it, so that was my second year of that. So it did change my life in a radical way.
What impact do you think the program had, what impression did it leave about the United States, about the CDC in Africa? Do you think it had an impact?
I think it was good. I mean, it may have been astounding, but when you're working down in the guts of an organization, one doesn't see the perspective of what others have about the whole range of things. I don't think we left a bad impression by any means, but that was nothing I was aware of or got feedback on.
You said your wife was traveling with you. What impact did the program have? I mean, did the smallpox eradication effort have on your marriage in terms of anything, traveling?
Well, we were unusual. We had just gotten married, and I was, my wife is a pharmacist, and we didn't have kids. And I thought that she could be extremely helpful in what I was doing. Sample surveys are not difficult to do. Keeping the records, drawing maps, things of that sort, she does very well. And so we worked as a team, and we continued to travel wherever we could as a team together. Now, she wasn't paid by anybody. I paid for whatever travel was going on, but we worked together all the time. And in fact, when I think about it now, it set an unusual precedent. We kept running into problems later in life when she would sit in on staff meetings or go to meetings with other organizations, and they would say, "What's your wife doing here?" Well, there would be administrative assistants, other people that would not be wives but would be sitting and listening in, and the fact that she was a wife alienated a lot of people, and we kept she eventually began introducing herself as my personal assistant. That seemed to work a lot better. But it was a very strong bonding effect on our marriage, and lasted throughout our professional lives.
Before we stop, is there anything else about the program, the Smallpox Eradication Program, that you think of that we should discuss?
Whether discuss or not, but I think that one of the extraordinarily important legacies was the group of people. Now, I just told you that the group of people was not extraordinary. They were ordinary people. But having gone through that experience, many of them continued on working together as colleagues throughout their career. And the smallpox program in West Africa morphed into the larger global program, with many of our staff from West Africa joining the global program and having major roles in that. I came back after spending some time at Harvard and then coming back to CDC. I went back to WHO in 1977, so I had left West Africa in '69. So almost a decade later, I came back at the recommendation of D.A. Henderson, who had worked at CDC, ran the global smallpox program, and of Dave Sencer, to go and replace D.A. Henderson at WHO and to run what was then a new program called the Expanded Program on Immunization, which was a child of the smallpox program. Even in the smallpox days, we were looking at how to use other vaccines with smallpox vaccine. How do we do this combined immunization? So a lot of the science had already been done by us in West Africa, plus others that were working on the same issue. And in 1974, the expanded program on immunization was adopted by the World Health Organization, which was an idea of taking what we knew about the smallpox experience, providing immunizations for a disease, and now doing a childhood immunization program. And that program faltered for a couple of years, and I was called in both because the program was faltering and because DA was leaving WHO. And there was a desire to have, at least there was a desire on the part of the U.S. to have a CDC U.S. person replace DA. And I went back to do that. Now, when I did that, a lot of the mafia I dealt with was the smallpox mafia, both the smallpox mafia that we had in West Africa, but the larger mafia that was then created when the program, the global program, was created. Because the global smallpox program was just phasing out, and suddenly I had a whole large staff of people who had that same motivation, who had that same perspective that came into my program now, the expanded program on immunization, and have now continued on to do polio eradication, the diarrheal disease program, a whole slew of very, very important public health initiatives. And that came, I think, directly from this initiative that was here in the West Africa, the smallpox group, then going to the larger international group, and that international group coalescing around several extremely important public health programs.
Do you think there will be another disease we can eradicate?
Well, we're trying. We're certainly trying with polio. There's some
and having some very difficult problems.
Yeah.
I think, in discussions. About
Yes,
whether
and it's a very interesting quandary in public health because you don't know when you're beginning if you're going to succeed. If you knew that, it wouldn't be a problem. You'd just get it done. We didn't know when we did smallpox in the beginning that we would succeed. In fact, we had to change the program radically in order to succeed. The same is happening with polio. Major technical breakthroughs, change of philosophy, change of the way we approach things, learning as we go, and having a lot of problems on the way. But that's the way you progress science. That's the way you get better. Now, it may come a day when we say, okay, enough is enough, we got to call it quits. But until that very end, I think it's absolutely well worth giving it the best shot that we can. For example, malaria was a situation where we tried and tried, and then it became increasingly apparent that this was not going to work. We didn't have the science. We didn't have the technical skills or the technical equipment to do the job. We had to change the goal of the program. That's not happened with polio yet. We have a lot of good arms yet to fire, and I don't think we should be anywhere near giving up at this present time. But there will be interest in doing measles. There will be interest in doing other diseases. And when I did the expanded program on immunization, coming in '77, people in WHO said, "Oh, Rafe, we know who you are. You're one of these eradication people. You just were interested in the short term." And I said, "Not on your life. I'm not interested in eradication. I'm interested in long-term childhood immunization." But I was interested in eradication in the sense that it is, and I came to that in the late 1980s when our routine immunization had more or less done what it could do. It was reaching levels that were not too bad, but were also not too good. And at that point, we adopted polio eradication, not only because we thought we were ready for it, but the polio eradication effort was one thing that stiffened us up in the whole other efforts, because we were dealing with a specific disease that helped us do the rest of the things and gave us more enthusiasm for doing those other things as well. And I do think that the occasional specific disease-specific initiative, whether it's eradication or radical control of a disease, can help strengthen a larger health initiative or set of initiatives and will remain useful public health strategies as long as we have both the combination of large sort of integrated services that we're doing and then some of the specific things that are within those integrated services. I think that combination remains extraordinarily important in public health and probably in other enterprises as well.
Thank you so much for speaking with me, and I think we've got some fine footage here. I am delighted about the details on the cluster sampling system. Nobody else has provided anything on that for me, so I'm very pleased to have that.
Good.